thanks for having me. I would like to thank the organizing committee and obviously the scientific committee, and particularly Javier and Ahmed, to have me here. And they also gave me the freedom to pick a topic myself. And first I thought I was going to go for something deformity or complex osteotomy. And then I thought about what my mentor always told me. I think disclosures are not going to matter for this topic. And I would like to pay a tribute to late Peter Schmiedek, who was my mentor, because he always told me, ask simple questions to common problems. And that's why we did studies on sequestrectomy and MIS decompression 20 years ago. And so I would like to talk about lumbar discs, which probably is the most simple and most common problem we treat. When we talk about indications for surgery, it's quite clear. We have those that we consider absolute, those that we consider relative. And when we talk about timing, there are many studies out there telling us you should not do surgery within the first 6 weeks, and you should probably not wait more than 6 months because you will have potentially a deterioration of outcome if you wait too long. Then Cauda-Equina syndrome is also quite clear, and there are nice studies out there that probably this should be treated within 48 hours. This is an emergency, and I think we all follow those rules. But in our practice, it was quite a challenge that how to decide on when to treat patients with a motor deficit and a lumbar disc herniation. So you have those high-grade cases, and then you may have those low-grade quad paresis. Patients can't really walk well, but it's not that severe, grade 4 out of 5, so you're not that worried. And then you discuss the timing, obviously, in your on-call team. And then the even worse problem is, do you get an MRI right away? Will you call the radiologist at night or on Saturday? And even worse, talk to the anesthesiologist. Are you going to do it on Friday, on Saturday, Sunday, next week? Or how are you going to treat those patients? So these are everyday problems that we are facing, at least in our scenario. When you look in the literature, and so the question was when to do surgery for lumbar disc herniations with motor deficits. And when you look in the literature, this is from a paper from Nikolaus Kögel, who I would like to also mention here because he did all or most of the work here. And you don't have to read this. There are quite a number of studies out there looking at timing, but the main problem is that data is quite poor, surprisingly poor for such a common problem. And if you look at the old studies published 20 years ago, there was no advantage found for early surgery, even though most surgeons would go for early surgery if you have a severe motor deficit, particularly for those grade 3 and less motor deficits. Now, if you look at the literature, just put out 2 papers, there are some more out there. And looking at foot drops, for example, if you look at the timing of surgery in those studies, they compared 8 weeks versus 2 weeks. But most likely, that's not going to make a big difference. So the mean duration in this study that you see on the left was 30 days. Probably after 30 days, it doesn't make a big difference whether you operate a week early or late. And the study also from the Dutch, nice study, they obviously excluded patients with severe paresis, so that didn't help us much either. They didn't find much of a difference in those grade 4 out of 5s. So the question that we wanted to address is, we looked at retrospectively at prospectively collected data, patients coming in as an emergency, acutely admitted, radicular deficits, and going for surgery, obviously. And we ended up finding about 300 some patients in 3 years. And this is again really telling my team that they've done a great job. They managed to get a 99% follow-up rate with an average follow-up of 5 years. So we really know they will not recover more after 5 years. And we grouped those patients being treated within 2 days, a week, or later than a week. And when you look at the data here, these are the severe deficits. Surgery within 2 days on the left, within a week in the middle, and after a week on the right. And if you treat those patients within 2 days, they almost all recover. If you treat them later than 7 days, not a single patient got full recovery. Not a single patient out of this group. If you look at moderate deficits, it's pretty much the same. A little better in the first week, but again, very good recovery early, no full recovery, treated after 1 week. And for mild deficits, this looks much better. If you have a mild deficit, which is a grade 4 out of 5 quad paresis, for example, you will have still most patients, about 3/4, will also recover even if they were operated late, and you will only have about 30% that do not recover completely. Then we were criticized when we published this, that this is retrospective data, so we looked at some prospective data and followed those patients for more than a year. 120 patients in this cohort, and we then looked at within 3 days and after 3 days, which was pretty much deliberate to see how those patients would recover. And this pretty much shows the same result. Severe moderate deficits, again now prospectively collected data, very good recovery if you treat them within 3 days, quite poor recovery for the severe deficits if you treat them later. And with the mild deficits, again, probably 2/3, 3/4 will recover even if you treat them later. And if you treat them early, obviously they will all recover perfectly. So we, in a collaboration with a Canadian group, we then looked at two of those studies, 400 patients, and looked at the mode of recovery in those. And because it's always somewhat problematic to really have a cutoff time point, we used unbiased recursive partitioning. So basically an algorithm told us what are the most important factors for recovery and what are the time limits for recovery. So how long can you wait and when is this going to change? Like the waterfall you heard in the talk before. So how fast is this going to happen? And it was very clear that the degree of motor deficit was the most important factor. Obviously, if you have a very severe deficit, they're going to recover worse than the mild ones. But then the second factor was already the timing of surgery. And we also published this in Neurosurgery some time ago. And I would like to really put your attention to that graph on the right. And then you see on the left side, this is the patients treated within 3 days, because that's the cutoff the algorithm told us, that within 3 days, the recovery will be very good. And after 3 days, that's when the waterfall, you're going down the waterfall and you have poor results. So mild paresis, perfect recovery, moderate paresis, perfect recovery. Even severe cases, about 2/3 will recover perfectly if you treat them very well, full recovery even in those very severe deficits. But if you wait for more than 3 days, again, mild is okay, but moderate and severe deficits do not recover well. Particularly those severe deficits, less grade 0 or 1, they will not recover if you treat them not within those 3 days. So that conclusion we took from that, treat those within 3 days if you want to have a good recovery. For those patients with moderate deficit, the algorithm came up with 8 days limit. So if you treat those grade 4 out of 5 within 8 days, they will basically all recover. If you treat them later, only 2/3 will recover. Meaning that obviously if you have a mild foot drop grade 4 out of 5, that's not going to matter much to the patient. But if you have, for example, a quad paresis, that will matter to the patients, even a grade 4 out of 5. So this is something that you can advise your patients on when to need surgery or not. And something I would also like to point out, if you look at the studies on stroke or the neurologists do those big studies with 10,000 people, and they always show you the number needed to treat. And you're already pretty good if you have a number of needed to treat of 8 or 9 or whatever. In this study, the number needed to treat early is less than 2, which is an amazing effect. I don't know any other study that I've ever been involved with where you have such an effect of treatment versus control, meaning treating them later. So in summary, I would like to conclude. Even though most of us advocate early surgery in patients with significant motor deficit, also for cervical and lumbar disc herniations, I didn't talk about cervical because we have less numbers on that. There's not been any evidence that you have to treat them within a certain time limit or as an emergency, because there has not been a specific time interval up until now. But from our data of 400 patients, we can conclude that motor deficits will fully recover if you treat the patient within 3 days. Even if they have a grade 0 out of 5, the results are very good. And though we now treat these patients as an emergency, and also argue with anesthesia about it. Those mild cases, grade 4 to 5, obviously mild foot drop, you don't have to worry much about it, but if it's a debilitating motor deficit, we also advocate the patient to go for surgery within a week, according to the algorithm, 8 days. And these results, I think, should affect our way of treating those patients and also talking to anesthesia, radiology, when to get imaging and when to get the OR for these patients also on the weekend. Thank you very much for your attention and have a great conference.
Thank you very much, Claudius.
Claudius, please have a seat. So
Sit
this
here
was
in
a
the
very
cozy corner.
nice review of the literature. And Ibrahim.
Yeah, thank you very much, Claudio, for your question and for your presentation. I have also a very easy question. Sometimes the patient comes to our consultation. He has a sciatic nerve pain, but he cannot tell us exactly when the deficit starts. How we deal with this? This is a very common situation. The patient comes, he was not examined before by any, and when you examine him, you find a sometimes deep like 2 on 5 or 1 on 5 deficit. How we can decide about that? Is the pain, if the pain is still there, is it, because my mentor told us that if the pain is still here, it means maybe that the deficit is recent. So what do you think about that?
Well, one thing, Ibrahim, thanks for the question. One thing is, it's actually not that easy, and this is one of the limitations of our study, that we don't know exactly when the paresis started, you're right. And we looked into that. To be honest, what we found is that the patients with a severe deficit, they all told us quite clearly this happened at a certain point in time. And also the other question that we always are told, we were trained that if the pain is gone, the nerve root is dead, and then you can't do anything. This is very uncommon. We thought this would be much more common. This is extremely uncommon. Those patients here, there were only out of 400, I think maybe 2 handful that would be considered something like nerve root death. This is very rare, at least in our practice. So I don't think this is that much of a problem.
Carmen?
Yeah, thank you, Claudius, for a great talk. And well, if it is all true, it would really change our daily practice. But can you please comment on the following? When I heard you talk, what came to me was that I was thinking that the patient who is operated within 48 hours is that colleague of ours, is that young mother comes in and says, yesterday I could run and now I can't anymore. And the other one who came in after the neurologist called after a week, like, what should we do? So that it is a different population.
I don't think so. Reason being that in our system, which is a problem of our system here in Austria, that they all come directly to us. The GP sends them directly to us. They don't see a neurologist, most of them. So which is a problem because we see so many patients in our outpatient clinic and in the ER. And the second reason being that why I don't think this is a true problem, that we have different populations, is that because of our OR resource problem, we like to treat them on call. Because then they are taken care of and they don't ruin our OR schedule 2 or 3 days later. You're right, it could be a problem, but looking at our referral practice, I don't think so. But obviously I can't be sure.
Okay, well, thank you. I will change my practice.
Yeah.
In your study, what is the electromyography comes within? Do you use electromyography to select some of the patients, or do you follow up with electromyography? Do you do pre-operative electromyography?
Very simple, no.
None of them?
None of them.
Why?
Because we don't think it's relevant. The patient comes in those patients all come in as an emergency. None of these are scheduled electively, obviously. So they come into our outpatient clinic or the ER. And first of all, within the first weeks, we don't expect much changes, and it would not change our attitude. We just try to evaluate as objectively as possible the grade of paresis, and we don't do electromyography on them. It may be wrong, but we don't.
Naresh Kumar, Singapore. I think you've alluded to partly in your presentation, but is there a difference between painful foot drop and a painless foot drop in outcomes?
As I said, the problem is in that series, the painless foot drops are so few that we cannot make any conclusion from them. Those patients, as I said, 98% had significant sciatic and significant pain. So I cannot conclude on those, which is a problem, but those patients we usually see late.
Yeah.
So we cannot conclude on those. I'm always asked, how do you treat those, or how do we treat those? I cannot conclude it from that data. Most likely, if they come back after weeks, it probably doesn't make a difference whether, and probably surgery is not that beneficial, and you can just not do surgery.
Okay.
But I don't know. I don't know that from this data.
Okay.
Yeah, microphone here.
Hello, Daniel Fress from Austria as well. I would have a question about the group receiving surgery later. Did age play any difference in motor recovery? Because at least in our clinic as well, we receive sometimes consultations with paresis of 4 out of 5 having longer than 8 days. So sometimes I believe we tend, if it's younger patients, that we are more proactive than older patients. So did you see that did age play any role in this, in motor recovery after 8 days?
Well, as I said, since we are probably not the experts in statistics, we just had those colleagues at ICORD in Vancouver do all the statistical analysis, and they did not find age to be relevant.
Thanks.
Moscow from Germany.
No, this one. Sorry. Please, I'm so sorry. Yeah, please go.
Yeah, Summer from Norway. I just wanted to comment or ask you about the methodology, because I thought it was a bit difficult to understand. And additional comment is, do you think it's reproducible in a regression model?
Probably I'm the wrong to ask, because I'm not a statistician. We discussed the different models, and we also did different analysis on the first study and looked at odds ratios, etc., etc., and the results were always the same. And that's why I think it's not going to change our analysis. In the first study that was published in Spine, we did a regression analysis, and that was basically the same interpretation of the data.
Yeah, so just another comment. So you had...
sorry, can we have the mic, because we have limited time. One last question and short answer.
Very practical question, Moscow from Germany. The most patients, emergency patients, you have made a decision, you suggest a surgery, but you know, they hesitate, they want a maybe second opinion to ask the family, the preacher of the village, and anybody, you know, this will be postponed in your surgery. Do you put it in the consent? Do you tell them the later the surgery, the worse the result? How do you do it?
No, we don't, because we also don't want to put us under pressure. Because if the patient comes in Friday night, we may not have time to operate him until Sunday morning because we are so busy on call. And obviously this is not a life-threatening emergency, so we don't do that. We tell them to do it as early as possible. That's how we get those different time frames. Because some patients come late, some patients come early, but they have to wait for 2 days to get the surgery, even if they may be on our ward. So that's how we got the variability of the timing in our study.
So thank you very much, Claudius.
Thank you.
Wonderful. Thank you very much, everybody, to be here. We have a coffee break right now. Next session in 30 minutes.